Good evening to all the respected viewers. I am Dr. Srishti Kapoor, your moderator for today's webinar. I welcome you all on behalf of Academy of Medical Excellence, and I extend my heartfelt thanks to Apex Laboratories for supporting this event through educational grant. So this is a continuation of a previous webinar wherein we talked about antipyretics and their safety in children. And today's webinar lays focus on one of the most common complaints being encountered in general practice, that is fever. So we have two keynote speakers amongst us. First, Dr. Anil Balani, a well-esteemed practicing general consultant physician from Mumbai, and Dr. Jan Thakuria, a well-known consultant physician from Faridabad. Dr. Anil Balani will enlighten us by covering the topic pyrexia of unknown origin. Over to you, sir. You can start the webinar.
Yeah, thank you, Dr. Srishti. Good evening, friends. Very encouraging to have all of you all on a Saturday evening. So now that we talk of complex things about angioplasties, about new anti-diabetics, but we should not forget all our basic thing like fever. And believe me, even after 30 years of practice, fever is one of the most tough things that gives us nightmares. It's simpler to treat a myocardial infarction, which has got a protocol, easier to treat a stroke patient. But believe me, when we have a hardcore FUO or a PUO, sometimes it takes us days to diagnose what is the reason. So a little brief about that. Let's move on to the next slide, please. So PUO was first described in 1961. It was termed FUO, fever of unknown origin, by Dr. Petersdorf and Besom. And the typical definition is a persistent fever above 38 degrees centigrade, which evades diagnosis for at least 3 weeks, including 1 week of investigation in the hospital. But as we know now that hospitalization has become very expensive, so in the modified one, we don't mention hospitalization. We can do most of the investigations on OPD basis as well. So hospitalization is not a compulsory feature. But fever, which is more than 3 weeks. Now, to evolve with time, this definition was revised by Durack and Street and divided into 4 main subgroups: the classic PUO, the nosocomial hospital-acquired, the neutropenic PUO, and the HIV-related PUO. Next slide, please. This makes it easier once we divide. This was the older one, which said that we need a hospitalization at least. What I showed you first was the newer definition. Next slide. How common is PUO? So PU continues to be a common finding in hospitals and ICU. And surprisingly, you will hear that even with the advancement in medical technology and increasing use of imaging tools, up to 50% of the patients still have no cause found despite adequate investigation. And I'm talking of a big hospital like Hinduja and Lilavati, where we have all the facilities, all the MRIs, all the scans. We have got transesophageal echo to look even for the minutest vegetation on the cardiac valves. So just a rough estimate, if we divide the percentage, infections constitute almost, say, 17 to 35%, inflammatory is 24 to 36, neoplastic is 10 to 20, and miscellaneous causes is 3 to 15%. In miscellaneous, we have drug, fever as well, which sometimes is an important cause. We've had a couple of patients who have had fever with all normal investigation, and all we had to do was to just stop the antibiotic. Next slide. So remember, FUO or PUO does not mean infection necessarily. So three general categories of illnesses account for majority of the classic PUO, which has been consistent throughout the decades. Infection, malignancies, the neoplastic, and systemic rheumatic diseases, which includes all types of vasculitis. We have lupus, we have rheumatoid arthritis, we have mixed connective tissue disorders. So these are all the various causes which come under autoimmune diseases, what we call. Next slide. But these are the three main important ones. And if we see the etiology by category, infections, among the infections is tuberculosis, abscesses, especially cryptogenic abscesses, intra-abdominal, sometimes in the prostate, sometimes in the sinus. These are common etiologies which present as PUO. Connective tissue disorders, we have Still's disease, which is the systemic juvenile idiopathic arthritis in younger patients. In elderly patients, we have the giant cell arthritis, and these are the most common rheumatologic disorders. Malignancies, we have lymphomas, Hodgkin's, non-Hodgkin's, leukemias, renal cell cancers, hepatocellular carcinoma, or metastatic tumors to the liver which produce fever. Drug fever due to a variety of drugs is also a common cause of PUO. And we have other unusual causes like factitious fevers, etc. Next slide. So it's very interesting to note that in developing country like ours, the most common PU appears to be of infectious etiology, whereas in developed countries, most PU appear to be due to non-infectious, mostly inflammatory diseases, malignancy, and autoimmune. This is a major difference in developed and developing countries. Next slide. What is the epidemiology? Scientific and technological advances have greatly refined and expedited the differential diagnosis and therapy of PUO. You'll be surprised to note that the fraction of undiagnosed PUOs dropped from over 75% in 1930s, where there was hardly any tools available, hardly any investigation, scans, 2D echoes, barely X-ray was available, to less than 10% in 1950s. Since then, the fraction of POs that are undiagnosed has steadily increased. In fact, with so much of equipment and advanced machinery, the fraction of POs that are going undiagnosed without any cause has increased. The early PUO series included few systemic rheumatic diseases, illness whose characterization has been benefited by careful clinical studies and developments in immunology. Extrapulmonary tuberculosis, solid tumors, abdominal abscesses are less prevalent due to early diagnosis by radiologic imaging like sonography, CT scan, and the minimally invasive biopsies. Exploratory laparotomy has given way to imaging and percutaneous guided biopsies for the diagnosis. Infective endocarditis, which used to be a frequent cause of PUO, has become less common with improved techniques for isolation of the organisms, the cultures. But unfortunately, in the current era, when the endocarditis is ultimately diagnosed in a patient with PUO, it is more likely to be culture negative because the patient has already received a battery of antibiotics, including intravenous, and it gets very difficult to isolate unusual organisms like Bartonella. Next slide. So if you see the percentage of patients with FUO origin by cause during 4 decades, how it has moved from infections, malignancy, inflammatory to others. And if you see from 1950s, where the percentage was 9 in undiagnosed, now in 2000, it has moved to almost 50%. Worldwide, the proportion of PO due to infection, connective tissue, malignancy, other etiologies very substantially based on the geographical and patient population healthcare exposure. The proportion of patients from whom no diagnosis is made has varied from 9 to 51% in studies published since 1990. And as I told you, over a period of time, now it seems to be increasing for reasons unknown. Next slide. Important causes that can lead to PO, which we should keep in mind, is tuberculosis, enteric fever. Why mentioning enteric fever? We all know about it, but unfortunately, it becomes very difficult to isolate the salmonella because the patient has already received antibiotics right from the GP level. Nowadays, we have doctors who give antibiotics at home also. And unfortunately, we are not doing blood cultures enough as soon as the patient comes with high-grade fever. So this gets very tough. Brucella, complicated UTIs, rickettsia, culture-negative endocarditis. EB virus is something that we often see. CMV, HIV, toxoplasmosis, malaria we all know and is very common. In the rare ones, we have histoplasmosis. In the malignancy, we have multiple myeloma, malignant histiocytosis, renal cell carcinoma, leukemia, and lymphomas, along with hepatocellular carcinoma. In the inflammatory, common are SLE, giant cell arteritis, PAN. We have granulomatosis with polyangiitis, rheumatoid arthritis, and the APLA syndrome. In the miscellaneous, we have drug fever, we have hypothyroidism, which can present with cirrhosis, which can present with fever. We have cirrhosis of liver, inflammatory bowel disease, and the last is the factitious fever. Next slide. So, as we know, now we have a battery of investigations available, which are very specific. With the advent of good antibody titers, we can detect CMV, we can do various serological testings, we have CTs, we have MRIs, we have blood cultures. So all this is helping us in the diagnostic approach. Next slide. I won't go into details of this, but we all know we have serious blood cultures, we have 2D echo, the transthoracic, and if we don't get on transthoracic, we go in for the TE, that is a transesophageal echo. For other diseases like Lyme, we have the serological, we have MRI to pick up early osteomyelitis, we have CT scans to pick up early sinusitis. We have various tests now, battery, to look for tuberculosis, including biopsies, including fluid aspirations. We have the gene expert. For uncommon infections, brucella, we have various serological testings. We pick up brucella and leptospira quite often in Bombay. And as we know, once we have the diagnosis, the treatment is quite simple of these. Next slide. We have adult still disease where we do ANA, we do the serum ferritin concentrations, we do the X-rays. Of course, our diagnosis all depends on a very sharp suspicion. We should always keep our eyes and ears open to pick up the smallest hint in the patient and then they delve deep into that. It's very important. Our suspicion index should be very, very high if we have to pick up anything, especially when we are dealing with autoimmune diseases, where we have again good serology, we have good antibodies titer, we have now ANA blot, we have RA factors, CCP for RA. So various tests are now readily available, especially in a city like Bombay, in tertiary centers like our Hinduja and Lilavati Hospital. Next slide. Some quick names I'm taking, various neoplastic. Again, we can do echo for atrial myxoma. Various biopsies of lymph nodes are available. We have OGD scopies to pick up GI tumors. We have colonoscopy for the colon. We have bone marrow biopsies. And the best is now the PET scan. Once we suspect any cancer, we can do PET scan not only for cancer, but also for infections. We normally coordinate with the nuclear medicine people and tell them that, listen, we are doing this PET scan for infections, or we are doing PET scan for malignancy. And then they do accordingly. They look. I've picked up quite a few patients with mediastinal lymphadenopathy on PET scans, which have turned out to be either lymphomas or tubercle. So these are very helpful investigations which cut shorts the various investigations that we keep on doing. Once we do a PET scan, we focus on the particular area, whether it's the thorax, the abdomen, or it's the extremity, and then they'll go deep into that with a good biopsy, if a tissue biopsy is possible. Next slide. So again, in cirrhosis, we have all the liver profile. In DVT, we do the Doppler studies. And in inflammatory bowel disease, again, we have CT scan, we have colonoscopy. So just to give you a bird's eye view of the various, next slide, of the various tests. Of course, how do we approach a patient of PU? A detailed history is very important. Medical history, past is very important. Travel history is extremely important, and a family history. With a meticulous clinical examination, physical, general, and a systemic, the respiratory, the cardiac, and the abdominal. Very important. Basic baseline tests like CBC, ESR, CR, kidney function, liver function, blood cultures, urine, chest X-ray, ultrasound, and an HIV. And then we do particular serology, advanced, we do a echo, we do a colonoscopy, dsDNA, we do an anti-CCP, chest CT, abdomen, lymph node biopsy. Next slide, please. If nothing helps, then a PET scan. These are some important red flags which we should not ignore. A patient who has fever plus minus but has weight loss, again, that should open our eyes that we are dealing with something sinister. Stool positive for occult blood, progressive weakness and lethargy, night sweats, fever with rash, hematuria. Patient says, lack of energy, I cannot perform my daily day-to-day task. These are all eye-openers, and we should take them seriously and investigate the patient thoroughly for any kind of infections or non-infection diseases. Next slide. Of course, it's very important that we must give more weightage in these group of patients who present to us with fever, like patient has previous ischemic heart disease, patient that suffered from stroke, or has pulmonary disease like asthma, like COPD, patient is elderly, 75 and above, a pregnant lady, and the temperature is more than 39 degrees centigrade, and children who have seizure disorders. Prognosis of mortality of PU is almost 30 to 40%, so we should not take it lightly. In elderly patients, mostly it is attributable to malignancy. If no cause is found, the mortality of long term is quite low, and fever settles down spontaneously after a couple of weeks. So these are some markers I've given you in diagnosing and treating a patient of PUO. Next slide. So as we know, paracetamol is the safest and the best antipyretic. We have lots of good data on paracetamol. We can use up to 3 grams safely per day. We should not start antibiotics without any direction or blindly. Steroids, of course, are out of question unless we have come to a proper diagnosis. The best is to identify the cause and then treat it accordingly. We should rather wait till we have a pakka diagnosis, then we can start with the relevant antibiotic and the steroids if they are indicated. Like autoimmune diseases, we all know, adult still disease, we know that they do need steroids, but then we must have the diagnosis before that. a word of caution, we should not use NSAIDs in few of the conditions because as we know, they can have a detrimental effect. So mefenamic acid is another choice, but of course, to be used with caution. Amongst all of them, as we know, paracetamol is the safest and the most common use, which we can till we reach the diagnosis. I think if we explain to the patient nicely that, look, you don't have to worry about the fever. We are trying to work on it. We are trying to diagnose what it is. And it's not necessary to bring your temperature to normal once we have diagnosed it. And then we will start with the specific treatment. Most of the patients understand and they are ready to wait. Thank you. I think that was the last slide. Next slide. Yeah, thank you. Yes, Srishti.
Thank you so much, sir, for such a knowledgeable session. We have few of the questions for you.
Sure, we'll take them now.
Yes, sir. So let's start with the first question. One of the viewers has asked, like, how often does fever of unknown origin remains undiagnosed? Like, what's the probability that we miss upon diagnosing it?
30 to 40%. So if you want in terms of percentage, I showed those slides also that of late, almost 30 to 40% of the patients can remain undiagnosed, even with an advanced tertiary center where we have all the facilities. So that's an important thing. Also, what happens is most of the patients have already been treated in the primary care with a lot of antibiotics, including oral, including injectables. So for us, when we get a patient at, say, Lilavati Hospital, which is a tertiary center, antibiotic-wise, the patient has already been messed. So it gets very tough because you don't get good cultures. You have to do repeated cultures. We have to do repeated serology. And sometimes after the second or the third time, in spite of first two serologies being negative or first one or two blood cultures being negative, it comes positive. Sometimes we are not so lucky.
Okay, sir. Another user has asked, like, are there any risk factors involved for fever of unknown origin, or is it that anybody can have that?
Oh, anybody can get it, especially if you are immunocompromised one. If you have comorbid conditions like you're a diabetic, you have a lung issue like COPD or asthma, you're liable to get respiratory infections. You are suffering from a malignancy, that is another immune. You are a cirrhotic, uncontrolled diabetes. So these kind of immunocompromised patients are more prone. But even if you have the best of health and you travel to a place where some disease is endemic,
Yes.
so you can get any kind of unusual. I've had healthy patients who have got wet in the rain and then they have come up with leptospirosis.
Okay.
So this patient was suffering almost for 6 weeks, but we managed to pick up leptospirosis and he was treated successfully. We had a couple of patients gone here and there, and they were exposed to animal unknowingly. He had gone to his friend's house in a different city. He played with his dog, animals. He's saying, I don't have a dog here, I don't have a pet. But when we got that history, so he was an absolute healthy person, 35, running about, doing gym. And we picked up brucella. So anybody can who has a travel history, gone to some unusual places which is endemic, or those immunocompromised patients can suffer from it.
Okay. Thank you so much, sir. One more question. Like, how do fever patterns help in the identification of the etiology of fever of unknown origin?
Yeah. Now, when we started with medicine, we used to have those various patterns of fever. You know, there were 3 or 4 patterns, undulating, recurrent, and all that. But now, when you come into practice, you see all that doesn't work. Okay, you can get malaria, simple malaria with different type of presentations. You can get typhoid fever with different presentations. So all those fever which we used to read before 30 years back, that you can diagnose this when you see this kind of fever pattern, honestly doesn't hold true anymore. It's
I
good
feel
for
that,
academic purpose, but that's about it.
sorry to interrupt you in between, sir, but I feel like with the changing atmosphere and the changing lifestyle and habits, it may differ from body to body and person to person because not every person can respond to it in a similar pattern.
True, very true. And the changing bacteria as well.
Yes.
The bacteria have changed so much rapidly and get into resistant form. So
One last question, sir. What are the historical clues to likely non-infectious inflammatory causes of fever of unknown origin?
yeah, that's a good question. So by and large, you don't get very high fever in non-infectious. You get 900. Second thing is, if the patient presents with rash, if the patient presents with arthralgia or arthritis, patient presents with glossitis. Okay, these are all some markers which should open your eyes to that we are probably dealing with a non-infectious cause. And we should look more into an autoimmune disorder.
Okay, sir. Thank you so much, sir. Now we'll carry
Thank
forward
you.
our interactive session with Dr. Jayan Thakuria, and he'll cover the topic fever with infectious diseases and its management in non-ICU and ICU patients. Over to you, sir.
Yeah, can you hear me?
Yes, sir, we can.
Yeah. Good evening, Srishti. Thanks for the invitation. And like sir already had described about the fever in details. So fever is something very interesting, and nowadays people are not concerned about fever because people are going into big things like angioplasty, stenting, replacement, but ultimately all operative cases, whether or stenting patients, even I've seen patients from the second day after surgery or from the very first day after surgery, they come to us that, sir, the patient is having high grade fever. We are not able to control the fever. They have done everything like replacement, stenting, and all operative procedure, but they couldn't control the fever. And patient been discharged with fever, and patient is not satisfied. They have been discharged. They came with something else, and they go back home with fever because fever is a like fever is something which is neglected by most doctors. They think that fever, nobody is concerned about fever. They are just concerned about the procedure. Now, let me tell you one thing. When we patient come to the OPD, we first assess the patient. We take the history properly. History is very important because from the history we can make a diagnosis. Almost say 50% of our patients are diagnosed from the history. Then comes the clinical examination. From there we get help from history and clinical exam. We can make from history and clinical examination we can make a diagnosis like 70 to 80% of patients are diagnosed. So for when the patient comes to take the history and for the clinical examination, it takes at least for one patient it takes at least 10 to 15 minutes time. But most of the doctors don't have time for so much time to go to the history, detailed history and the examination. So we miss most of the like causes of fever. Like as we are taught in MBBS and in post graduation, that when a patient comes in the OPD, we take the history, we take the family history, we take the personal history, then we go to the past history. Then from the history, we go to the examination. From the general examination, we have 17 to 19 points. If we thoroughly cover the 17 to 19 points, we can cleanse the diagnosis. Suppose patient come with fever, low grade fever, and patient from the history said that he or she is a vegetarian. So then the thing that cleans into your mind is whether the patient is vitamin B12 deficiency, because vitamin B12 deficiency also can lead to fever, mild fever. Secondly, we examine the patient, we find lymph nodes. From the lymph nodes, we can make out whether the patient having any local infection, like say ear infection. Most of the patient may not present to you with any discharging pus from the ear, but from the examination from lymph nodes, we can make out he or she may be having kind of local infection from the local site. Then one of the common cause of fever in this part of the region, that is northern India, due to pollution, is sinus, that is, and the pollution and weather is, and change of weather, as well as from the there is sinusitis, maxillary sinusitis, ethmoidal sinusitis, or pansinusitis is one of the most common cause of fever. Almost we get 20 to 30% of patients of fever are a plain sinusitis. Just do an X-ray PNS and the proper history. Ask the history about nasal blockade, post-nasal drip. We can make out the diagnosis of fever from there. Nothing is needed. Just give a short course of amoxiclavulinic acid. The patient responds. Then we go to fever like coming with in certain period of the year, like this time of the year, post monsoon. That is, most of the fevers are like mosquito-borne fevers. We come with dengue, chikungunya, and malarial fever. So all of us know that chikungunya symptoms, fever will come with rashes, with joint pains, and patient may come in a wheelchair. Then comes the malarial fever. Those fever also we know it's a high-grade fever coming at an interval. I mean, then comes like most of the fevers in a young lady. If the fever comes, then we suspect newly married girl or young lady. We may suspect the patient must be having urinary infection. Okay. Then comes a fever with say a low-grade fever, not responding to antibiotics. He or she has been showing to doctors for last say 1 month. Most of the fevers coming in the evening hours, say 100, 101, 102 maximum. Then the thing that come into mind is whether he or she is suffering from tuberculosis, because tuberculosis is very common in this part of the country. And second thing is that the patient may not come with the typical Cox presentation, pulmonary tuberculosis like cough, fever, and weight loss. He may come with a low-grade fever in the evening, rise of temperature, lethargy, he's not feeling well. So we should rule out tuberculosis by finding out any lymph nodes, or by doing an X-ray, or if required, a CT scan or an ultrasound to rule out any lymph adenopathy. Then comes I'm talking of the most common fevers. Then comes typhoid fever. Now, typhoid fever is something, enteric fever, which is misdiagnosed or falsely we diagnose as typhoid by saying a typhi IgM or Vidal positive, because these are the tests, these are the immunological tests. These are not the clear diagnostic tests for typhoid fever. To say a typhoid fever, we should find bacteria should grow in the blood culture. If the patient have bacteria grows in the blood culture, Salmonella typhi or paratyphi, then we can label as typhoid fever. Otherwise, the other condition, a fever with hepatosplenomegaly, with supportive diagnosis like typhi IgM or Vidal, with other invasives like malaria and other fever cause. If you rule out, then we can think of typhoid fever. And the treatment is, as we know, is mainly if patient stable, we discharge with cefixime 400 milligram twice daily. Or if the patient is say sick, then we admit the patient, put him or her on injectable ceftriaxone, and if required, we add on azithromycin. Those should be given as per your body weight, like 50 to 75 milligram per kg body weight per day. And as the fever subsides, it comes down in a step-ladder fever that is gradually come down with treatment. Then we taper the treatment or switch over to oral medications and discharge the patient. And normally we discharge the patient when the patient is afebrile for at least 24 hours. Now, these are the normal fevers in day-to-day life. Now, some fevers, we don't find anything like blood culture negative, urine culture negative, X-ray normal, ultrasound normal. Only thing is that we find a high ESR. We should do a HSCRP also, because HSCRP is a very important marker to rule out patient is having fever or any inflammatory disease. Now see, fever may be due to infection, due to any inflammatory disease. Now this disease, like sir already explained to us, the rheumatological diseases like lupus, rheumatoid arthritis, or in fact in psoriasis. So we can have fever. Now, like lupus, what we need to do is just do a ANA test, or if we have a urine routine, just look for hematuria. If you have hematuria, there's no pus cells, there's no stone, patient is having fever, we should think about lupus. Right. Now comes like fever, some of the like points we should look for: whom to admit, whom to not to admit, who require ICU care, who doesn't require an ICU care. Now patient, a fever patient coming to you with convulsion, with severe headache, with say blurring of vision, or say insensitivity to light, neck stiffness, pain abdomen, recurrent vomiting, rashes, breathlessness, fall in saturation, burning urination, or say urinary retention, he having a blood in stool, or increased frequency of motion, bowel habit, loose motion, with fall in BP, patient going towards shock, BP going less than 90/60, patient like is a disoriented, so he or she will come to your OPD, whether either in a wheelchair or in a stretcher. He'll be disoriented, restless, toxic, skin rashes. Those patients we need to admit immediately. Those patients need immediate hospitalization. Now patient having these symptoms, we should immediately try to first shift to ICU if the vitals are not stable, and if the patient have any disorientation or say organ involvement, shift to ICU, send a blood culture, urine culture, a procalcitonin test, thoroughly examine the patient, remove the clothes, properly examine the patient, look for the source of infection. Normally, most of us don't do when the OPD, because we don't look for, say, prostatitis, prostatic infection, or we don't look for perianal abscesses. We don't look for, say, psoriasis or skin lesions around the navel area. We don't look for joint pain. We don't look for tenosynovitis. Those are the things that give us a clue towards the diagnosis. We don't look for the knee, whether it's any inflamed knee or swollen knee. Those are the important ones. We don't look for bony tenderness like osteomyelitis. So this will give us a clue to the diagnosis of fever. Then we shift the patient, send proper examination, send the cultures, send culture from different sites, blood cultures, send urine cultures. If the patient has already been treated outside by a local physician or say by other doctors and he come to your hospital in the tertiary center, then the culture may come out to be negative, but other things will give us a clue, like procal will give us a clue whether it's infective or non-infective. If the patient has already taken antibiotic for a longer duration, 10 days, 14 days, injectable outside, patient is still having fever, then we should look for other things like whether the patient is having in an immunocompromised state, whether patient history-wise, occupation-wise, whether patient having any immunocompromised, immunodeficiency state like HIV, whether the patient has been given a lot of antibiotic and patient develop drug-induced fever like ceftriaxone. We find monosef patient taking monosef for longer duration, the patient itself develop fever, and fever doesn't come down with monosef after giving or ceftriaxone after giving for a long duration. So we should stop all the antibiotic then. We should see whether patient on these medications are having any infection like fungal infection, which is the most common cause of fever in ICU, which is missed most of the time, and patient die of fungal infection. The fungal infection is one of the most common cause of PUO in ICU settings, because most of the patients are not seen for fungus. We look for all big diagnoses, but we miss or we don't go to look for this simple fungal infection. Number two, patient having on medications. So like antibiotics for longer duration, stop the antibiotics, see, look for the fever. First, send all the cultures, then go for the scanning. Most of the fever, when it comes in the second stage, like leptospirosis, what we found with leptospira, first week fever, become fever, the patient fever comes down, again come with the second week, the next spike of fever, the second week. Then it become an immunological phenomenon. Most of the, like, few of the disease, not most, few of the disease goes into immunological phenomena when it goes in the second week. So there the role of vasculitis come into play, and role of whether we are missing something like vasculitis in leptospira. Okay. Then similar is for in also in fine sometimes immunological phenomena in dengue fever. So immunological phenomena is another cause of persistent fever in any infectious disease. If the patient infection goes or fever goes beyond second week, I mean first week, and it goes in the second week. So we should look for the immunological phenomenon. Then the role of steroid comes when the patient's immunological phenomena goes, the patient goes into immunological phenomenon like we had during the COVID times. COVID is another where we find fever in the initial side, then patient goes in immunological phenomenon. There comes the role of steroid. For that, we look for markers like HSCRP. The HSCRP will be very high. It will be more than 100, 150. Normally infection, it goes, say, like is less than 5, it goes about 10, say 50 10, or 20, 30. But in severe infection or in immunological, then it goes more than 100, towards 150, 130. Then we should look for all the immunological phenomena. Now, fever in any young patients, we should look for, so as already said, we should look for any cardiac infective endocarditis, any cardiac, we should auscultate the patient, we should sense for the murmurs. Once the patient is in ICU, we should maintain the airway, we should maintain the circulation, we should maintain the BP. Patient shouldn't go in, we should try to, I mean, patient if is in shock, we should try to maintain the BP, because if it is a systemic, it goes into systemic infection or sepsis with multi-organ, then it becomes very difficult to patient come out of the sepsis. Like fever, few fevers few patients, a few fevers are very high, hectic fever like abscess and pyogenic infection. One of the important source of cause of fever is, which we miss most of the time, even in ultrasound also we miss, that is liver abscess. We find that patient comes with the OPD with fever. If we don't examine the patient, if we don't find intercostal tenderness in the right lower coastal margins or right lower coastal space, intercostal space, then there's a possibility that we may miss a liver abscess, because most of the time in the posterior segment, if there's a evolving liver abscess, then the ultrasound may miss the evolving liver abscess and it may report normal. But after 1 or 2 days, or if you go for a CT scan, then the patient's liver, abscess can be seen. So liver abscess is one of the important cause of fever in any immunocompromised patients, or mainly in alcoholic patients. So that is also a clinical diagnosis will help us to cleanse the diagnosis. Now, fever is something region to region is different. Like in northern India, cause of fever is different. In eastern India, it's mainly malaria and encephalitis, viral encephalitis, Japanese encephalitis. By northern India, we mainly fever are mainly like dengue, then COVID, then waterborne diseases are more common. In similar in this western and say southern India, waterborne diseases are common, leptospirosis are common. Post-monsoon fever, sole cause of fever are different. Then during these winter months fevers mainly due to airborne disease, or say like the pollution in fact pollution helping for the airborne disease to spread the airborne disease. Then comes fever in this time of the year, winter season. We have to look for fever like influenza, flu, normal flu, or say H1N1. So even a few years back, we had COVID during this period of time. So fever differ from locality, from area to area. Now, history is important, because whether his patient has any contact history is very important to rule out sexually transmitted disease. Any travel history, that is important to find out whether which part of the country he's traveling, like whether he's traveling to any forest. Then we have to find out for like tick-borne fever. Rickettsia is one of the most common cause of fever, scrub typhus. So we should, by examination, if we find a scar like thing, or a black spot like thing, like bitten by a tick or any insect, that is one of the cause of fever. That's not, most of the time is we miss the diagnosis, because we don't expose the patient, see the patient properly, because that is the source of fever, and that patients respond only to doxycycline, so which is not commonly used. So then comes like investigations have already told about the thorough examination and thorough investigation to be done. If the fever doesn't respond, then we should go for a PET scan, because PET scan may give us occult tuberculosis, occult malignancy. We miss normal examination or normal scan, or vasculitis, or any autoimmune disease. Like one of my fever patient came with fever, only she was made a diagnosis of Takayasu disease, because of a PET scan showing the different say vessels involvement. Then we find out by measuring both the arms with BP, difference in BP in both the arms. Normally, people don't do, when the patient comes to OPD, we don't look for BP measurement in both the arms. So there's chance of missing a patient, a case like Takayasu. Another thing is patient coming to me with psoriasis with erythroderma. So erythroderma patients already on psoriasis treatment may also come with high grade fever, not responding to anything. So, but these patients takes time to come for fever to come down. Normally, people immediately start with steroid, but steroid should be avoided because steroid will give you a temporary relief of fever in erythroderma patients. But once you stop the steroid, it will again flare up. Disease will flare up and the fever will again come. So we should know the diagnosis, what we are looking for, what we are thinking about. First, make the diagnosis, then go for the treatment. Antibiotic is something which is used as per the local antibiogram, like what are the bacteria or virus or say pathogens growing, what it is sensitive to. Different ICUs have different, have different antibiogram or say pathogens. So antibiotic, once the patient comes to the OPD or he or she have been shifted to ICU, we think about the first do the culture, scan, rule out, do ultrasound, rule out of the diagnosis, peripheral smear. Once we send all the samples, then start the antibiotics. Antibiotics something if you're having the suspecting a URI or LRTI, lower respiratory infection, we go for gram like amoxiclav. In the ICU setting, we go for higher antibiotic like tazobactam or meropenem. Because in ICU settings, we go with high antibiotics. Once the fever comes down, things are under control, sepsis is under control, organ involvement is not there, vitals are stable, then we step down the antibiotics. Then we shift out from the ICU. Now, the thing that is that are you misusing the antibiotics by straight away going to high antibiotics? That is very common nowadays. We are finding very difficult to treat patients because now previously we are finding ESBL E. coli. Now we are getting multi-drug resistant E. coli. It's not responding to any drugs. We have to go for high antibiotics. So rationing or proper rationale of use of antibiotics is very important. Not to use a polypharmacy. Don't blindly or go straight away with multi antibiotics, multiple drugs. So I've seen some prescription patient has been given with amoxiclavulinic acid, then the patient has been given dalacin, the patient given antifungal, he has been given antiviral, he has been given steroid. So this will just make the case worse, and it will be difficult for the patient, for the doctors if the patient deteriorate, because we don't have any thing or any thing in our hand to be used the patient deteriorate, because the patient will go into multi-drug resistance. Number two is the recycling of the antibiotics in the ICU settings. We don't need to carry the same antibiotic for years or for months and months. We need to recycle the antibiotics, because something's very important thing is that we don't have to make the antibiotics used for longer time, because the bacteria or bug or fungal bacteria or whatever bacteria pathogens there, that will become resistant and the antibiotic will be of no use. So recycling of antibiotic is very important. Now the thing is that a patient on ventilator support or in an ICU, the chance of nosocomial infection is very high. So we should see that we can shift the patient from the ICU as soon as possible. Say the earlier we shift out from the ICU, the better is the patient for the patient, and the chance of nosocomial infection is less, because ICU is the area where you have all the different patients with different all severe condition carrying with different bug. So there's a chance of cross infection by, let's say, by the healthcare professional dealing with the patients, there's chance of giving infection from one patient to the other. The proper hand sanitation, this proper hand washing, hand sanitation, wearing a mask are important. And if possible, one-to-one nursing care is important. So, isolation of few patients who have been who are having a highly infected cases should be isolated. Like we have like uh, a closed cabin for inside the ICU, a closed cabin for the infected patient, so that that doesn't spread or say to the other patients, or say a chamber with a negative pressure ventilation. So those things are very important for dealing with ICU patients. Now, like I don't want to go in details about the treatment modalities of like tuberculosis, typhoid, bacterial pneumonia, malaria, because most of the people know how to treat malaria, how to treat bacteria, or how to treat the abscess. Abscess is something which after draining out the pus culture and sensitivity, we give the antibiotic as per the sensitivity report. But normally we give a gram-positive cover-up or with a anaerobic cover-up. Okay. Now we come to the like few things are miss. That is the like fever, factitious fever. Patient may come to you that I'm having fever, but he or she may not be having fever. Like one of my patient admitted day before yesterday, he has a case of ILD. He is giving us a fever, but there's no fever recorded. He wants to go for a bronchoscopy because he's scared that he must be having a tuberculosis, because there's a past history of tuberculosis to this patient almost 10 years back. So proper counseling of the patient is important. If we counsel the patient properly, if we make a clear diagnosis, if we tell the patient what you are having and what is the time period you need for us to recover, for you to recover, and what will be the complication, what will be the side effect, I mean, what will be the like time period, what are the drugs you need to take and for what duration, then it becomes very easy for the patient to understand as well as for us to treat the patient. Like a patient on immunocompromised state, or a patient having diabetes, COPD, heart failure, and a patient on anti-cancer drugs, malignant drugs, or immunosuppressions, those patients should be properly vaccinated. That is very important. Vaccination is an important part because we can prevent them from having fever, which are the common fever with the change of season. Like we should vaccinate before the winter season. We should vaccinate the patient, say during the August month. So it takes at least 1 month for the vaccine to immunity to develop. So vaccination, like pneumococcal vaccination, influenza vaccination, should be given just before the winter, because we can prevent them from having infection and coming with us, landing up in our OPD with fever. The high risk groups are the comorbid patient with comorbid conditions, patient, like elderly age group, patient on say like dialysis, malignancy, on anti-cancer drugs. So we should vaccinate them properly. Now there comes fever. Fever, whenever a patient comes to fever, we start with plain paracetamol. Paracetamol is the safest, and we can, until unless there's any kind of allergic reaction to paracetamol in the past, after taking the history, paracetamol is the safest. Like as sir said, 3 gram up to go cannot go up to 3 gram per day. Now, paracetamol, if doesn't come, fever doesn't come with paracetamol, then we start cold sponging. So that helps in to bring down the fever. Sometimes, say fever doesn't come down with paracetamol, then we can use mefenamic acid, but we should be careful that the patient is not suffering from low platelet, dengue fever, or any kind of GI upset or any chance of having a GI bleed, because then it will be difficult to manage if the patient bleed after giving a mefenamic acid. Paracetamol is the safest in children and in adults. Ibuprofen normally is something given in only few selected patients after screening the patient so the patient doesn't go in any kind of complication. Antimicrobial is only given when you make a diagnosis or after sending the sample. We can start with antimicrobial. Like in the ICU settings, we start with meropenem. Or if you're having a chest infection suspecting, we then go for tazobactam. Then in a non-ICU setting, we go for amoxicillin or ceftriaxone as after making a proper diagnosis. So fever is something it's a very big chapter, tip of the iceberg. That is just tip of the iceberg. It can give anything, any disease can lead to fever. Even after say after a knee replacement, that metallic reaction or body rejection to say kidney transplant patient, body rejection or any that can give rise to fever. Fever is just your body response to a foreign antigen. So fever is not a diagnosis. It's just giving us a clue that something is going wrong inside the body. So fever, when you come to fever, patient comes to fever, we should history, proper examination, and a thorough history and examination, and say our you should keep our eyes and ears open and see where it fit. And as Sir said before, not to use steroid in fever, but because that may flare up any underlying condition. If the patient is having tuberculosis, that will flare up. Steroid may help you for few days to suppress the symptoms, but it's a very harmful drugs if you are not making a proper diagnosis. So I would rather recommend first do a proper take a proper history, proper clinical examination. Then only we make a diagnosis and then start the antibiotic. Counsel the patient properly, because fever inside in a say a typhoid fever, it takes time to come down. It won't take time, like you cannot bring down the fever in typhoid in the very first day. It comes down in a step ladder pattern. Similarly, in malaria, you will have fever until unless you give an anti-malarial. It will take time to settle down. Fever, if we have thrombocytopenia, we should look for all the mosquito-borne diseases. Fever with renal involvement or urinary infection can be urinary infection. We should look for pyelonephritis, because patient may not come to your with all the symptoms of urinary tract infection, but on ultrasound or CT scan, we may find sign of pyelonephritis. Patient with fever, and young girl with fever, you're not finding anything, just scan and look for atrial myxoma, which is rare, but it's a life-threatening condition. The patient may collapse at any time, but patient may present to you with fever. And say patient may or may not present to you with chest discomfort. Then comes fever with convulsion, headache, rigidity, neck stiffness, rule out brain infection, any infection in the brain. Fever with altered sensorium, with 1 day or 2 day history of fever with altered sensorium, instantly we should rule out infection brain, mostly encephalitis. Patient coming with fever, with night sweats, we should look for any kind of lymphoma or malignancies. Fever coming, evening rise of fever, low grade fever for long duration, we should look for tuberculosis. A vegetarian people may have low grade fever, we should look for vitamin B12 deficiencies. Fever with joint pains, rashes, we should look for if it in for short duration, we should look for chikungunya or mosquito-borne disease. If it is for a longer duration, we should look for autoimmune disease. Fever with rashes, look for exanthematous fever. Fever with only urine hematuria, but there's no stones or no source of infection, urine infection, look for lupus. Fever with joint pains, single joint pain, look for septic arthritis. Fever with, if you find a person, traveler going to forest or site, or with coming to you fever with a scar, look for something like scrub typhus. So fever is something we make out the diagnosis from the history and the examination. So here I want to conclude further because it's a very big chapter, and I just in a nutshell I've told you about the different causes of fever, and how to go forward, how to manage the fever initially, and how to from there onwards, according to the organ involvement, we go for the further treatment and management. Thank you, Srishti.
Thank you so much, sir, for such an insightful session. We have few of the questions from our viewers. So, Dr. Sharma has asked, like, use of antipyretics or cooling therapies, which is better and why?
See, antipyretics, obviously, whenever you have fever, first start with cooling therapy, but cooling therapy normally it takes time for to come down the fever. So antibiotics normally we can use safely if there's no any contraindication. And paracetamol is the safest in children. We, as you say, the 15 milligrams or 20 milligram per kg body weight, or to maximum up to we can go to 3 gram per day in a day. The duration of the interval should be at least more than 4 years, 4 hours. And for fever for 1 or 2 days, we can start with just paracetamol. Wait for 24 hours or say 48 hours. If the fever doesn't subside, then you show to to respected doctors or your local physician.
Okay, sir. And another question is, like, which is the most reliable method to measure body temperature in ICU patients?
So rectal temperature is the most important. Oral and rectal, these are the two ways we can measure temperature. Temperature can be measured by putting your hand over the, we can feel, or the other oral cavities, ear also. But the most common is the oral and the rectal. So that give us a, accuracy is more.
Okay, sir. Anil, sir, we have one question for you. A viewer has asked, like, how do peripheral doctors diagnose the fever of unknown origin?
Fever of is asking me, fever of peripheral doctors, fever of unknown origin is a diagnosis of exclusion. You cannot make a diagnosis straight away of PO. PO is something, it needs duration of 3 weeks time. You cannot make the very first day, you cannot make a patient of PO. First, we need to have the basic test. All the basic tests are hemogram, LFT, KFT, urine routine, urine culture, blood culture, chest X-ray, ultrasound, echo if possible. When, if the patient history, if that he's a say a driver by occupation, sorry to say a truck driver, then we should offer by occupation we should rule out HIV status. If we rule out the basic things, these are the tests, screening tests. Then only can go after 3 weeks times. If fever doesn't come down, then we can label the patient as a PUO or for that. But without doing investigation, we cannot make a diagnosis of PUO. PUO is a diagnosis of only exclusion.
Anil sir, your views on it?
Yeah, that's right. I think Dr. Thakuria has given us a very exhaustive and detailed talk about various POs and how we should pick up signs. So now, even in a peripheral center, the basic labs are all available, like a basic CBC, the blood work is available, X-rays are available, ultrasound is available, and a little bigger peripheral centers, even CT scan is available. So by and large, we can pick up a lot of common causes of PO in our country. And the thing is, we should not think of uncommon things. Common things are really common. That is the first adage in medicine. So we should think of simpler things like typhoid fever, malaria, dengue, tuberculosis, and then think of exotic diseases. If you concentrate on these, by and large, you have covered most of the diseases that happen locally. Okay, and with these basic investigations available, we are able to pinpoint what is the cause. But as Dr. Thakuria said, if 3 weeks of fever, you have exhausted your investigation list and you still have not come to a conclusion, patient is deteriorating, then I think it is better to send the patient to a tertiary care center where better facilities are available.
Okay, sir. One last question we have. C-reactive protein or procalcitonin, which is more promising lab investigation?
See, procalcitonin is to rule out infection from non-infection. C-reactive protein is when high, it will show either it's inflammation and infection. But procalcitonin doesn't show inflammation. It's only for infection. C-reactive will be high in both autoimmune disease, very inflammatory conditions, and infective condition. So if you want to look for infection, then it is procalcitonin. Okay, and if you want to look for inflammatory markers, then it's a C-reactive protein.
Okay,
Also,
sir.
what
Yes,
we have marked is with CRP, the level of CRP rise, one is a marker of worsening infection. So we do repeated CRP levels. Okay. If the patient has reducing CRP clinically better, then we realize that we are on the right track. We are treating the patient properly. The second thing is the level of rise of the CRP is very important. In viral infections, usually the CRP is between 50 to 100. But when you're dealing with severe bacterial infections, of course, one of the methods is to consolidate it by doing a PCT. But if the CRP is more than 250, 300, definitely we are dealing with bacterial infection. So that's another way that CRP helps us in not only diagnosing what is the type of infection, but also whether the patient is responding to our treatment.
Okay, sir.
Yeah.
I feel we have covered almost all the questions raised by our viewers. I extend my heartfelt thanks to you both for such an engaging and informative session. And I, on behalf of APEX, Academy of Medical Excellence, and PASI Healthcom, would also like to thank all the viewers who have been a keen listener throughout and have been supportive. I wish to see you all super soon in a third webinar under the same academy. Till then, stay safe, take care, and wishing you all a very happy Diwali in
Thank you,
advance.
Thank you.
Srishti.
Thank you.
Thank you for the nice academic session.
Thank you, sir.
Bye bye.
Thank you.
Thank you so much, sir.
Thank you.
Thank you so much, sir.